because if we will not graft the area, the whole site will collapse. We have done many studies like these animal studies. There are plenty of clinical studies to read how bone grafting in such everyday scenarios will help to have better healing and will restrict the resorption of the area, so we'll have more bone and more soft tissues for the next stages. So we need to do bone grafting. In most of my cases, I'm using the silicate beta TCP. I'm always using synthetics. So my first choice for grafting such sockets will be to use the Powerbone PUTTY. So we fill the defect, and what is also for me essential is to have open healing. What I mean by saying open healing, secondary intention healing, is that I'm not raising the flap to cover the whole area. I just reposition the soft tissues at the initial place, and then I will let this on top, I will let this to heal spontaneously under secondary intention healing. We do this so we don't raise a flap, we don't advance a flap. It's good to avoid doing it, because if we pull the flap to cover the graft, then what is going to happen? We have some problems, and these are important problems, like we have a coronal advancement of the mucogingival junction, we reduce the keratinized tissues, and we have more pain and more swelling. But the biggest problem is that by raising and pulling the flap, we move the keratinized tissues from the buccal area on the top, and then we have biological and aesthetic problems. So we do the socket plug technique in most of the times, which is open healing. So this is how we use the Powerbone PUTTY, the paste of silicate beta TCP. It's preloaded in the syringe. We don't need to mix it with anything else, just to apply it directly in the socket. And what we can do is we can take a simple collagen sponge, cut it, make it like a thin, nice membrane, let's say. So I'm using this hemostatic sponge like a membrane on top. So with an instrument like this one, gently, I place the collagen over the Powerbone PUTTY, and then I just place a few crisscross stitches. Then we wait, and we can see after 4 months that we have a good healing. So there is, of course, some resorption, but because we did the socket graft, we have limited the atrophy. And because we followed an open healing approach, you can see that on top of the bone graft here, we have spontaneously new soft tissues. We have newly developed keratinized soft tissues just because we let it open and we had secondary intention healing. We do the reentry, we do a small flap, and you can see that the whole area is filled with new hard tissues. Remember, it was just a big hole. We were missing here completely the buccal plate. We didn't have any septal bone. It was a big defect. And just in 4 months, you can see that the synthetic bone grafting material very quickly guided the cells and helped the body to reconstruct here and to produce good quality hard tissues. That's the point. That's why we use these synthetics. That's why we do the bone grafting, the socket grafting, because we need to assist the blood clot and we need to help the area here to fill with high quality bone quickly and effectively. So you can see all this is regenerated new bone, what big quantity we have. So it's very easy now to do our planning, to place the correct implant at the correct positioning. Also, when we place implants, we need to be very careful how deep we will place these bone level implants. We need to use a caliper, and always we just place back the soft tissues because we need 4 millimeters from the platform of the placed implant to the zenith of the soft tissues. This is a basic rule, but it's very important to follow it because we have to place deep enough our implants to allow for 4 millimeters vertical space for the biological width. After placing the implant, the best way then to think about the soft tissues is to use anatomical customized healing abutments like this one here. So instead of just fitting a small stock healing abutment, we can fabricate it chairside, or we can design it with software and mill it. We can use anatomical abutments to fit them onto the implant and then just reposition the soft tissues around the anatomical abutment. And what is going to happen is that the abutment will guide the healing of the soft tissues. As we can see here, after 3 months, it's easy for the patient to brush it and keep it clean and control the bacteria. And the implant is placed in very good quality bone, so we wait for the integration of the implant, and at the same time we have the maturation of the soft tissues because the abutment guides the soft tissue healing. So when everything is ready, just after a few months, the only thing we have to do is to remove the abutment, and you can see the implant is integrated into the bone that we created with the bone graft, and with a correct anatomical abutment, we have also reconstructed the profile and the anatomy of the soft tissues. So now we are ready just to take an impression and the lab to make the restoration. Everything is published. We can send you all the papers to read in detail all these ideas and techniques. So you can see now that the lab can make a very good restoration from titanium and zirconia, because these materials will connect to the soft tissues. They will attach to the soft tissues to make the soft tissue seal. And you can see the final result. And this is 2 years after. We have the remodeling of the high quality bone because we created using the resorbable synthetic, good, excellent, high quality of vital bone. And because we have a good soft tissue profile, a soft tissue seal, a good restoration with good selection of biocompatible materials, and we clean it, then we have very good, excellent, and most importantly, long-standing results. We have long-term stability, which is the key to keep our good results for many, many years. Okay, so we saw this case, how using these materials we regenerated the bone, which is the first very important step. And when we have good bone, we can place the implant and do all the simple steps. As you can see, everything is quite simple nowadays, to go here, get there, and finish the case nicely. And we know exactly what we are doing because we have well-defined protocols. So Dr. Zan explained very nicely why we develop, why we research, and why we're using these synthetic materials. The most important is because they will give us the highest quality of bone. We are doing orthopedic procedures. We need to give back to the patient the highest quality of the missing bone. We are not just doing some bone augmentation. Of course, there is no risk at all for disease transmission. And also for our daily work, we need something handy, something that makes our work easy, something that it is easy to apply. So we have better handling and we have less invasive procedures. Which are the indications? In which cases we can use such materials? It's not for all the spectrum of cases, but it can give us a very good solution in the majority of our everyday cases, like socket grafting. It's ideal to use it to treat extraction sockets in small contained bone defects, in small peri-implant bone defects, for immediate implant placement to fill the jumping distance around the placed implant. As I'm going to show you later, for small internal lifts or for lateral sinus augmentations when we place at the same time the implant, so the implant will give us the tenting effect, the stability of the lifted sinus membrane. And we can use it also when we want to regenerate quickly and good quality of bone in intra-bony cysts, when we remove lesions from the bone and then we need to use a bone grafting material to assist the bone tissue healing. Okay, because as I told you, the quality of the hard tissues is one of the pillars of successful uh, bone grafting, of successful dental implant treatment, and we focus on this. I don't really want you to get confused, but we need to know the basics. And the basics are that we have xenografts, synthetics, allografts, autogenous, as Dr. Zan very nicely explained. And the most important thing to understand is that every single material, according to which category it belongs, it has different properties regarding the resorption and regarding the new bone formation. So they are not the same. They are different. They work in different ways when we use them in the body. And what's very important is to understand that we need to choose the correct bone grafting material. Like if we go cycling, we need to choose the correct bicycle, because if I choose this child bicycle, then I will have an accident, and it's not a problem of the bicycle, it's problem of my selection. So silicate calcium phosphates, silicate beta TCP materials. There's lots of literature to read about their osteoinductivity, about how they are conductive, and how they produce the highest quality of bone. To see this in our cases, what we need to do with humans is we need to take a bone biopsy. Let's say here, before placing the implant for our clinical studies, we take from the regenerated bone a trephine biopsy. So with the trephine, we remove a small part of the regenerated bone, and then we go to the microscope, we cut all this, we cut the trephine with the bone graft, and we measure how much new bone we have, how much connective tissue, and how much residual graft, to assess how the bone graft is working and to see if the bone that we regenerated with the bone graft is good quality or not. What we see constantly with those materials is that after 3, 4, 5, 6 months, we get excellent quality of new bone. In this biopsy, after 6 months, we can do the measurements with the software, and we can see that we have around 50% of new bone. This red here is the amount of the new bone. And also, we need to note that we have a very small amount of bone graft. So this here, the blue, is the bone graft, because these bone grafts are fully resorbable. It means that after a few months, this is after 6 months, they get resorbed. And when they get resorbed, they give place to very good quality and a very good amount of new bone, as we can see in this biopsy. And it's not just our biopsies. This is a very good systematic review by Jamhekar, and they analyzed all the clinical studies that they have biopsies like the one I showed to you from humans that they did socket grafting with different materials, and they tell us from the systematic reviews exactly what we see every day using these materials, that when we fill sockets with synthetics, we get the highest proportion of vital bone and the less amount of graft material. here after 12 weeks compared to all the xenografts and all the allografts. So that's why I'm using these materials, because they will give me the best bone around my implants when I'm using them. So we see the histology. The histology is giving us the answers about many questions, and I can understand what I'm doing with my patient. So we see here the new bone. This gray particles here is the power bone that is breaking down. And all around here we see an amount of connective tissue, and all those little black dots are the cells. Why this is so crucial, as we discussed in the previous lecture by Dr. Ozan, is that this silicate beta TCP is osteoinductive. So it is osteostimulating. It means that the silicate component is charging negatively the surface of the beta TCP particles. So the particles here, they have a negative charging because of the silicate around them. And what that does, it is attracting the binding proteins of the cells. So all these little dark cells, and you can see how dense is the number of cells around the grafts and the new bone here. And all those cells are attracted by the silicate component of the bone graft. That's why we get many cells that are not differentiated, or osteogenetic cells. All these cells will transform to osteoblasts, and that's why we get very good bone and very quickly, because we have this osteostimulation. We guide the cells by adding the silicate component. Also, what else is happening? Because this is resorbable, you see that the particles are breaking down. And when the particles are breaking down, they release calcium, they release phosphate ions. So they provide to the cells all the nutrients, what they need to create new bone. That's why we need to use fully resorbable materials. They will break down, they will give food for the cells. The silicate will attract more cells to the area, and all this will have an excellent osteoconductive and osteoinductive effect. And this is what will give us excellent, high quality new bone. We know this very well. We know this in bone biology, in orthopedics. This is a paper published in the Proceedings of the National Academy of Sciences of the United States. This journal is among the 3 top cited journals in all the fields of science. And in this top journal, Habibovich and her team, they published an amazing paper. They analyzed all the studies, they have all the evidence, and they explain how beta TCP, calcium phosphate, bone grafting materials that we use in orthopedics and now we use in dentistry, they are inductive. So it means they stimulate the stem cells to become osteogenetic cells, to become osteoblasts, and to give us the perfect bone when we use them. And we know this also for the products we are using, that when we implant them into muscle, like in all the studies and the tests that have been done, we create bone into the muscle, and this is the proof of osteoinduction. So we know exactly that the materials we are using are not just conductive, but they are also osteoinductive. And this is very important. They have excellent macro and micro porosity. You can see here the micro porosity of the particles. This is a particle of Powerbone dental putty. So the micro porosity of the particle of the graft is optimized. And so you can see here that the new bone and the cells and the tiny vessels, they develop and they go inside the dissolving particle of the graft. And we can see it here, how the new bone, or this is the new bone, is in contact and is developing inside the macro and micro porosity of the particle of the bone graft. So we have developed, we are researching, we are using the state-of-the-art synthetic materials, and the aim is to create the highest quality of vital bone. And because we are doing science, we are doing orthopedics, we need to know this, and to understand this better, what we are doing in the bone, in the jaw bones of our patients, we can also do 3D analysis of our bone biopsies. So we can do a micro CT, we can analyze everything in 3 dimensions. We place the specimen, the bone graft, and the new tissue in the scanner, and in 3D we analyze it. And this is important because exactly in this tissue we are going to place our implant, and we need the implant to be placed inside high quality bone. We need to have very few dissolving or not at all graft particles around, because we need very good integration, and also integration means the connection of the implant with bone. It doesn't mean the connection of the implant. It cannot happen with particles. And why bone architecture is important, bone quality is important? Because we load the implant. It's biomechanics, it's a kind of orthopedics. So when we place the implant into the new bone, eventually we will load the implant. It means that we will send all the occlusal forces through the tooth, through the restoration, through the abutment, through the implant to the bone. This is why we need to create high quality bone, because the bone will need to remodel. When we stress the bone, when we apply forces to the bone, and that's what happens when the patient is biting, the bone gets these forces and needs to remodel. By remodeling, and this is forever, it's a constant mechanism of the bone, by remodeling the bone becomes stronger, and we can see this also to our x-rays, how the bone remodels. The bottom line is that we need to use fully resorbable synthetics because they will give us the best quality of bone, and it means we'll get forever the best remodeling of the bone. So you can see all the cases when we use the bone grafting material, how it models, how it is resorbing, and at the same time it gives genesis to the new bone. And then when we place and when we load our implants and we keep taking x-rays, we can see that this becomes better architecture. It is remodeling, so it becomes denser, it becomes stronger to adapt forever to the biting, to the occlusal forces. And last thing I want to show you regarding these studies, I want to show you the micro CT. So the micro CT is in 3 dimensions. We analyze the new bone. So this is new bone from an area where we used a resorbable synthetic. So the synthetic gave genesis to high quality bone. If we go here and we scan this from top to bottom, and we see this on an axial plane, as we go all the way into the new bone, you can see that we have created trabecular bone, high quality bone that has some very few amounts of residual bone graft. So we can see in 3D that the new bone has an anatomy, an image, an architecture of natural trabecular bone. That's what we want to create. That's why we use these bone grafts. If we use xenografts, or if we use HA, if we use materials that they don't resorb, and it's very common to use such materials, you can see that the hard tissue has a totally different anatomy. It doesn't look, when we do the examination, like trabecular bone. It doesn't look like vital bone because it is consisting of 30, 40, 20% of xenografts, of highly mineralized hydroxyapatite which is not remodeling, it's not resorbing, it stays like that, and it is giving us a very poor quality of bone. All this is very important because we are scientists. We need to do an orthopedic procedure. We need to give back to the patient the highest quality of bone. This is another case. You can see that, again, we have a very big defect after removing the tooth and the underlying infection and cyst. We clean everything. We use our dental PUTTY. I do my grafting. Again, I favor open healing, and we can use membranes on top. We have now very nice dressing materials to protect the area, but to let it to heal open. When it heals open, we have on top very good quality of soft tissues. And when we open, in all our cases, we see that we have regenerated with these materials excellent bone. Simple procedures, you see, I'm not using any membranes. I'm just doing a good extraction, cleaning, and grafting with Powerbone PUTTY. And we can see just in 4 months, everything is filled with very good quality of new bone. We place the implant. Be careful with the placement. We need the surgical guides. We need good planning, where to place the implant, how deep to place the implant. And then with a nice anatomical abutment, we can also condition and reconstruct the soft tissues. Another case, another molar extraction, again, no bone, just a big hole, Powerbone PUTTY, open healing, again, the same pattern of healing. I get less atrophy, I get all the new keratinized soft tissues on top. I raise my flap, again, I see that I have excellent new bone. This is after 6 months. To place my implant, look, all the regenerated bone where initially I just had a big bone defect. Another abutment, again, very easy, very predictable, simple steps. I have the same result. A similar case, I remove the tooth, I clean it, I remove all the infection. I use my oxygen-releasing blue M gels to control the bacteria in all the steps of my treatment. This is the Powerbone PUTTY. Again, open healing. You can see the secondary intention healing. The bone graft is in place. We have new connective tissue, and on the new connective tissue, the epithelial cells, they proliferate to close the gap. And after just 3 or 4 months, we have the healing, the same flap, small papilla sparing site-specific flap. Again, everything is filled with new bone. We can see here some little residual particles of the graft. This will go away. We place the implant, we place the abutment, and again, we have the result. So as you can see, we do the same thing again and again, same techniques, same materials, and we do the same again and again because it works. These are proven protocols, solid protocols that you can try and get the same results in a very simple way. So some key points, take-home messages before we see some more cases. We need protocols. In whatever we are doing, we need to have our protocols. We need to learn very good atraumatic extractions and surgery. We need to control the bacteria. We need, in most of the cases of socket grafting, open healing. You can use membranes, but I like to use wound dressings like Oraid, Copac, Elemental. You can try the periacrylic tissue adhesives. So in the market, you can find some very nice wound dressings to cover the grafted sockets and to allow for open healing. And always we are using fully resorbable silicate beta TCP synthetics because in a consistent way, they give us the best quality of bone. And then when you place your implant with your surgical guide, if you will see how to use anatomical customized abutments, then you can facilitate the reconstruction of the soft tissues in a very simple way. Let's say case of immediate implant placement. This first premolar was broken, a vertical crown and root fracture. We could not save the tooth. This is the broken tooth. So in this case, we did the extraction. Again, minimally invasive extraction. We try not to damage the buccal plate and the soft tissues. You can see here the fracture. There was nothing to do to save this tooth. And in this case, we opted to do an immediate placement. So you see, it's very crucial to find the correct 3D positioning. We have guides. You need to use something to guide your hand to place the implant at the correct position and at the correct depth. How deep? Again, I'm telling you, we need to measure at least 4 millimeters from the platform to the zenith of the soft tissues. This is a basic rule, but it is a very helpful rule. And then we need to do some kind of dual zone grafting. It means that for these immediate placement cases, when we place our implant, then we fill all the space down to the hard tissues and all the space around the soft tissues with a bone grafting material. Again and again, I like to use synthetics. Here I use the crunch, the thin, small diameter particles of silicate beta TCP to do my dual zone bone grafting. And to seal this, now that I placed my implant and I achieved good primary stability, I will not place a stock abutment. I will construct and I will fit an anatomical abutment, because the anatomical abutment is following the anatomy of the extracted tooth. So it fits perfectly because it has a customized anatomy. It fits the anatomy. It is following the cervical anatomy of the tooth. So we have the ideal sealer to protect the graft. You see here, the abutment will protect the graft that we use for the dual zone grafting, and also it will guide the soft tissue healing. That's all that we do for these immediate placement cases. Then we need to control the bacteria. So every day, good hygiene and oxygen releasing gels every day. So during all the healing period, they will control the bacteria. Because if we get an infection, we'll have a good dehiscence and then we can lose the bone graft.